Thanks for being here and being interested in this topic. I like the way Wade set me up. I have a couple of non-competing disclosures to make here because I'm just talking medicine. But I have an ambitious list of objectives. So I want to talk a little bit about acceptable recovery target. I think we got a pretty good idea what that is. When neoglyco, when Sugamidex. If I use Sugamidex, can I just skip the train of 4? Because that stuff works pretty well, it seems to. And is some neuromuscular blockade reversal always required? So that's a heavy lift in a few minutes. I'm leaning heavily on the guideline parameters that came out this spring that are referenced there. So acceptable recovery, I think we all agree. It's a train of 4 ratio that doesn't have any significant fade, so at least 90% of your baseline. That gets us away from the normalization argument with some AMG devices. And it's from the thumb. Doesn't count from up here. Might work from the adductor hallucis, but there's not a lot of evidence. If you're going to twitch monitor, kind of the details matter a little bit. So the most prevalent monitor is simply a qualitative. The weakness, as Wade pointed out, is we are not reliable at discerning whether we have minimal blockade. So we have a train of 4 ratio somewhere between 0.4 of 0.9, and it's easy to not be able to tell that's what it is. So I'm going to give you a couple of twitch to look at, and it's going to play first the twitch, and then it's going to play again with the quantitative cover. Everybody got a number in their head at the end of the case? Do it again. That was a 50%er. Let me give you another one. So that's visible fade, so must be less than 0.4. So if one of them got you, you're human, right? You're representative of other people, and that's kind of where all this push towards quantitative monitoring really comes from. Now, a quantitative monitor, which is typically an accelerometer, so something measuring motion on the thumb, or a compound action potential EMG monitor, something sort of in the thumb pad and the thumb not looking at movement, gives you a number. So you don't have to guess, you don't worry about observer error. So if you are going to monitor for acceptable recovery, you got to think about the device I have. If I have a qualitative monitor, I'm actually never, ever positively sure. So there's an uncertainty that's left over after my clinical assessment. If I have a quantitative monitor, I have certainty, but I have technological complexity, I have some expense, I have a hassle factor depending on what I'm working with, and then I have some unfamiliarity because these just aren't as prevalent. So block depths, if you look down there, it's shallow. So I have a train of 4 count, but I have a ratio of less than 0.4. I can generally see if somebody's got a fade. I can eyeball that. The minimal block, which if I extubate somebody with that, I've extubated somebody who has residual neuromuscular blockade, I don't reliably tell that that person is in fact weak. Acceptable recovery, I can only get with a train of 4 ratio of greater than 0.9 of where I started, which is tough to do if I can't make this differentiation of a minimal block. So when neostigmine and glycopyrrolate, the point I want to make here is that, is that neostigmine is ineffective at complete block, it's ineffective at deep block, it's not preferred at moderate block, so that's a train of 4 count of 1, 2, or 3. It's Sugammadex is still preferred at shallow block, and neostigmine doesn't rise to, hey, this is the recommended way to reverse until we have minimal block, or we think we have recovery, but we want to secure it by giving a small dose of neostigmine. So it doesn't have a big role, even though many of us have used it for many years in a big role, but that's why we have this problem that we're tackling. So these are profiles that were made with the software that is being released by the Anesthesia Patient Safety Foundation this weekend, and the dashed line is spontaneous recovery. So think of this as twitch suppression down here. I got post-tetanic of nothing all the way up to the green line is a 90% twitch ratio. If at deep block, I get neostigmine in the full dose, I hardly get any separation. This is a 3-hour time scale, so it's not very obvious, but I got a 46-minute recovery with neostigmine, and I got a spontaneous recovery in 51 minutes. Overwhelmingly, it's a spontaneous recovery. Same thing happens at twitch count of 1 to 3, and of a shallow block where I have that lower ratio. I don't get much benefit. When I get to minimal block, the spontaneous recovery is in 14 minutes, and if I give neostigmine, I hit my target in 6 minutes. So I get the benefit of the time at the end of the case without it dragging out. So qualitative peripheral nerve monitor, as you've already heard. If I think somebody's recovered and I'm just using a peripheral nerve stimulator without a number, I'm advised to still give a low dose of neostigmine out of an abundance of caution and then wait 10 minutes because you can't be certain. Or you can give Sugammadex, a dose we can talk about later if we want to. When is Sugammadex effective? Sugammadex is effective for any block except complete block, and that's simply because that's outside of the package insert. Doesn't mean you can't use it when you don't get a post-tetanic twitch. It's simply not recommended for that. Ideally, you don't need somebody in a complete block because you've monitored and then prevented them from getting there. So this is what the Sugammadex curves look like at deep, moderate, and shallow blocks respectively, and you can see the separation. And you see how the deeper the block is, the bigger the separation from the neostigmine line in each one, right? So this begins to get closer as you get to shallower blocks. How come neostigmine doesn't work so well? Because it just inhibits acetylcholinesterase, and you have a hard time making enough extra acetylcholine, absent the acetylcholinesterase, to overwhelm the equilibrium constant at the neuromuscular junction. If I use Sugammadex, is it okay to not use a train of 4? The answer is no. And let me tell you why. This is why. And this is a fabulous paper, comes out of University of Washington by Bowdle et al. And I would encourage all of you who are a tiny bit interested in this to read this paper and go, aha, that's why I've seen what I've seen and why I still need to monitor, even though many people say, I don't have to monitor, I gave Sugammadex. So they titrated this in cardiac surgery patients, and in people who started out with a twitch count of 2, by the package insert they need 2 per kilo, they had a 16% failure rate, didn't get to that target ratio of greater than 0.9. And the people with deeper blocks who got 4 per kilo, in other words, they had a post-tetanic count of 1, the failure rate was only 8%. So Sugammadex is really good, but it's not really good in every single patient, and you can't predict prospectively who that's going to be. Some people needed a bunch more, a whole bunch of people needed a lot less. So verify that you hit your target. Is some neuromuscular blockade reversal always required? The answer is it depends. And so this comes out of the guidelines statement. Patients with adequate spontaneous recovery can be identified only with quantitative monitoring, and these patients do not require pharmacologic antagonism if they hit your target, 0.9, 0.92, depends on what device you're using, 1.0. If you're using a peripheral nerve stimulator, non-quantitative, you still got to give something because you don't know. Now, the guideline says that they don't absolutely require antagonism, but they acknowledge that we probably need more data. Doesn't mean you can't do it or shouldn't do it. Just if you're going to do it, monitor your patient. And by doing it, I mean not give reversal at the end of the case. It's a big deal because there's a price impact between neostigmine and glycopyrrolate. So it's a $100 decision every time you decide to give Sugamidex versus neostigmine. And it's at minimum a $13 decision, potential saving, system-based practice, if you give nothing to reverse because you've achieved your target via spontaneous recovery, as happens in lots of cases, particularly if you use smaller doses of rocuronium to initiate your case, right? 0.6 per kilo is really 2 times the ED95, but we use it simply because it sets up a little bit quicker. Okay, so guideline summary, Wade already covered this. If you're gonna do this, do quantitative monitoring and do it at the thumb, ulnar nerve stimulation. Sugamidex is recommended for deep, moderate, and shallow depths. If you don't have it on your formulary, I think you can lean on these guidelines to coach up your pharmacy. Neostigmine is still reasonable for minimal blockade, so that's this. I can't see a fade, but I'm suspicious there might be one there. And patients with adequate spontaneous recovery, so using quantitative monitoring, if you hit 0.9, you don't have to antagonize them. And in point of fact, I have patients every week that I don't want to antagonize because they get there. And then you have a chance to talk to them afterwards. Remember that hitting 0.9 isn't strong like we are here in this room today. It's tolerably weak. You can't go up a flight of stairs effectively if you're greater than 0.9. But you ought to be at least that far before you consider somebody for extubation if you use neuromuscular blockade. Thank you.